Good morning, everybody, and welcome to the Colorectal Cancer Program Highlights Symposium, sponsored by the Cornell Sphere of New York Presbyterian. We have a full agenda, great speakers, interesting topics. We're going to try to keep it as interactive as possible. I will be watching the Q&A for questions between speakers. So feel free, if you are participating, to enter your questions in the Q&A. It's at the bottom of the Zoom, and I will run it between speakers. It's really a pleasure and a privilege to have Dr. Josh Smith here with us. He recently moved to MD Anderson to be the chair of the Department of Colon and Rectal Surgery at University of Texas MD Anderson Cancer Center in Houston. Is getting settled in, I believe, in his new job, and he has done a lot of work on watch and wait from the very beginning, and we are fortunate to have him talk to us about the present and the future of watch and wait. So, Dr. Smith.
Great, thanks, Dr. Figuera. All right, can you see my slides and hear me okay?
Yes.
Okay.
Yes.
Great. I'll get started. So thank you again for the kind invite, and looking forward to talking to you about something that's certainly near and dear to my heart as somebody who likes to operate, but still at the end of the day likes to give the patients an opportunity to preserve function if at all possible. So here are my disclosures. Just want to have a warm welcome from the folks here in Houston. Here's the current group, and we're growing. So if you know somebody who wants to live in Houston, we're definitely hiring, and the group sends a warm welcome to the folks in the Northeast and old neighbors at Cornell. So I'm going to go over the problem of rectal cancer, the surgeon's dilemma, changing paradigms, how we're saving rectums, and also trying to make an impact in terms of changing survival. I'll go through the data, some opportunities that I think exist currently, just review some next steps, and then summarize where I think we are in the current state of things. So this is one of my patients who came to me with only an option of APR. And I think the only regret that I have in her treatment is that because of my move to Texas, I was unable to go to her wedding this past spring in Italy, but she still has her rectum. She's 7 years in. And so, I think she exemplifies this problem that we're seeing with patients that are young, less than 50, in both of these age groups, 20 to 49, but also you see this rise in those 50 to 64. So I think this is the group that's emerging out of this young onset group. And so I think we just need to be very careful. But we see these patients in our clinic over and over again. They were half of my patients this week in clinic. So we want to reduce the risk of distant metastasis, preserve quality of life, identify sustained responders, and make treatment more individualized. And I'll get into both of those topics in just a second. So locally advanced and early rectal cancer treatment, it used to be patients either went straight to surgery for an early stage tumor or chemoradiation and then straight to surgery. But those days are, I think, long past. And now the idea of chemoradiation and chemotherapy with TNT is in place. And then also this idea that not everybody needs surgery is certainly coming on board. And then I'll show you some data that maybe not everybody needs chemoradiation. The current dilemma for surgeons, however, is how do we identify sustained responders? And this is an idea of a patient who had what looks like a very nice complete response, but at the end of the day, developed a local regrowth at 40 weeks post TNT, excuse me. So how do we identify those patients so we can better counsel them at the beginning of treatment? So the foundation for a lot of this was built by Dr. Garcia Aguilar in the timing trial, where they essentially flipped the order of things and did chemoradiation and then chemotherapy with the idea that if you gave additional doses of chemotherapy that you could improve response. And in fact, that's what you see is a dose-dependent increase in pathologic complete response and an association with improved disease-free survival. And this study was a building block for many others that I'll mention this morning, including the German trial. This is AIO 12, where they randomized patients to induction chemotherapy and then surgery or consolidation, which is what I mean by that is chemoradiation, then chemotherapy, and then surgical resection. And in fact, they saw a higher rate of pathologic complete response, similar to what Julio saw in the timing trial, and then no differences in oncologic outcomes using this approach of long course chemoradiation and chemo versus induction TNT. Now, when you ask about induction TNT, of course, that's the way that it was done historically at Memorial when I arrived. And this was tested in the GI-002 study by Tom George, where this was a platform study where they used a control arm, which is FOLFOX and standard chemoradiation and surgery, versus trying to use radiosensitizers like a PARP inhibitor or Pembro. And they noted no differences in the response outcomes here. And then in mature data that he presented at GI ASCO in 2023, there was no differences in the PARP arm or in the Pembro arm using this approach. So really no differences in either the pass CR rates or the clinical complete response rates. But what he did see is a large participation in this trial from young onset patients, which is very interesting. And this trial did accrue very quickly, but unfortunately didn't meet the primary endpoints, and the publication for this is still pending. So the timing trial also, and the idea that you could give radiation first was also tested in the Rapido trial, but using short course NTNT versus just a standard chemoradiation approach in surgery. And the primary endpoint was disease-related treatment failure, and they did see a difference using this approach. However, you fast forward to more than 5 years follow-up now, the problem that they're seeing in this trial is higher rates of local regional recurrence, as you can see here. And it was thought this time last year that maybe this was just due to delivery of poor quality radiation in certain sites. There may be some poor quality surgery, less conformal RT with short course, and maybe a lower dose. But really, it looks like the failures from those that underwent sphincter preservation surgery, where the rates are 12 to 5% versus no difference in those who underwent APR. So there's something about the way that this was done in Rapido that led to these local regional failures. And this is the paper in British Journal of Surgery that just came out last week, if you want to refer to it to dig into the data a little bit more. So the question really is, can we change survival? And this was asked and then answered by this study called Prodige 23. And they compared standardized treatment, chemoradiation, radical surgery, adjuvant therapy versus a triplet approach, FOLFIRINOX, and then chemoradiation, and then surgery. And you can see that all of the outcomes were improved: pathologic complete response, disease-free survival, metastasis-free survival, essentially doubling the pathologic complete response rate. But this is the important slide, is that they have shown that there's improved disease-free survival and overall survival with this regimen at 7 years, which I think is important, and one of the first trials to show a survival benefit in the past 15 years. And I'll allude to another trial that's shown a survival benefit on this slide. I won't get into the details because the final long-term data is not out yet, but it's called the Stellar trial that also used a short course approach, TNT, similar to Rapido. But we see that when you use this TNT approach, that you get an increase in pathologic complete response. There was really no overall survival difference in Rapido, but definitely in Prodige. And it looks like there might be a signal in Stellar, but we'll wait for the long-term outcome in that study. So the second paradigm shift that I think really changed the way that we think of rectal cancer patients in the modern era was laid also by the work done in timing, and then carried forward by Dr. Garcia Aguilar, my clinical mentor and prior boss at MSK. And this study was very unique in that it randomized patients similar to the German trial to long course chemoradiation chemotherapy, then induction chemotherapy, then long course, and then used a 3-tiered clinical response assessment to determine, can these patients preserve the rectum? And if they had a near complete response or a clinical complete response, and that near complete response evolved to a beautiful clinical complete response, they could undergo watch and wait. If not, of course, they were recommended surgery. And what you see here is very interesting, and it's that more than half of the patients preserved the rectum at 3 and 5 years. And this was much higher than predicted. Initially, for the study design, it was predicted that you would see a difference of 35 versus 25%. And you can see that this was completely blown out of the water compared to what the statistical design showed that it would have been or what we had predicted, and no difference in oncologic outcomes, as you can see in the right panel. The important thing is, as I noted, the local regrowth rates, and you can see they're lower when you use chemoradiation up front versus chemotherapy up front, as seen in the OPRA trial. These are the 3-year and 5-year rates, consistently lower. And the disease-free survival, importantly, is similar for those who went upfront surgery versus those who had a regrowth, and sphincter preservation rates also importantly were not different. So what are the take-home points from Oprah? And thought about this a lot. And the key things are that more than half of the patients were able to preserve the rectum. There's a higher rate of organ preservation using this consolidated TNT approach. And the predictors of organ preservation in the subsequent publication were EMVI, the mesorectal fascia status, nodal status, and tumor link. So these are all important things to consider when you're counseling patients. So I think watch and wait is certainly here to stay, and we've all, I think, experienced that in our practices. And this was certainly ushered in by Oprah. This shattered the paradigm. This checked off the boxes of response, safety, and efficacy, and it really suggested that sequence matters. So I think when you when you think about what you want to do with your life, I always think of it's nice to be able to do a clinical trial. And when I was explaining how this worked to my kids long ago, they said, "Well, what does Dr. Garcia Aguilar do?" And I said, "Well, he helps with this trial idea to save people's rear ends." And one of my kids said, "Oh, well, he's saving people's cabooses." And in fact, in this trial, you can note that he was responsible for saving more than 100 patients' rear ends, which I think is really a big deal, and he deserves a lot of credit for this, and it's really changed the face of rectal cancer to date. So where are we now? If you look at the follow-up study, so this is the German group back again in AOI or AIO 16, and they tested this as they're moving forward to a trial that I'll mention a little bit later. So they had 93 patients, 88 who made it through treatment using this consolidative approach. They had a lower clinical complete response rate at the beginning. I think they're a little bit more conservative with 33 of these 88 with a near clinical complete response. At the end of the day, their clinical complete response rates in the 30s, and they did allow patients with a near complete response to evolve to a clinical complete response with time, and I'll show you the data there shortly. But you can see that, interestingly, using this approach is almost identical to timing. The only difference is this is 3 cycles of FOLFOX after chemoradiation, that the CCR rate is 37%. Remember, in timing, it was 38% past CR, so it's really on the money there. Their complete response rate, however, if you combine clinical complete response and pathologic complete response, is 63%, which is very interesting because in OPRA, the past CR rates were much lower than that. So it suggests that maybe in this cohort, they were pulling the trigger a little early on some of those patients. So 47% underwent TME. And I think the take-home points are, as I alluded to, the clinical complete response and the pathologic complete response are very similar when you compare this trial or this study to timing. And then their near complete response to CCR rates were higher than what we saw in OPRA. In OPRA, we saw a conversion rate of 50%, here 63%. And I think maybe that's just because they were maybe a little bit more conservative and had not been doing watch and wait for a long time. And again, this is long course and 3 cycles of FOLFOX. And the path-CR rate, as I just alluded to, is much higher than what we saw in OPRA, which I think is very interesting. Suggests that still by endoscopy and MRI, we're not perfect by any means at picking out those patients with a sustained response. So why is this important? Well, when we look at oncologic outcome, we can see that if you compare those who in another German trial where everybody went to surgery, you can see by response that if you had a pathologic complete response, your outcome is quite good. If you had an intermediate response, it's in the middle. And of course, you have a poor response, your outcome is worse. And we see the same thing in OPRA. If you look at patients by clinical complete response, near complete response, or incomplete response. In a validation cohort, this is outside of the protocol at MSK. We published these data last year. You see the same thing. CCR and NCR patients certainly are different with an intermediate response versus a very nice clinical complete response. The DFS rates are also different, which is not surprising in what we saw in OPRA, but no differences in overall survival. So this is an important study. I'll take just a second to unpack this, but this is comparing the OPRA data versus the study I mentioned earlier, the AIO-12 study, where the patients were randomized to induction versus consolidation TNT, similar to OPRA. But remember, in the German study, everybody went to surgery. In OPRA, we gave people it was a selective use of watch and wait. So we wanted to see, are the outcomes different if you went to surgery versus not if you had these three response criteria that I just mentioned, so good, intermediate, or poor. And you can see, in fact, the oncologic equivalence, whether the patient went to surgery for mandatory TME versus selective watch and wait, which I think is really important and foundational when you think about these data. So what are the perks and the benefits of watch and wait, or sorry, a TNT? There was a little bit of a slip there for me. Of course, it's watch and wait in the context of OPRA, but you can give chemo before or after radiation. We know you improve compliance. You can treat micrometastatic disease, enhance responses, as I've shown you. And I think for the surgeons in the group, we know that when we give TNT, we reduce our time to closure. I usually schedule my closures in those patients that I take for robot LAR, essentially at the time that they finish TNT, and I know they have tumors, because I know that as long as they heal well and do fine, that we don't need to wait a prolonged time to close the ileostomy. We know from PRODEUCE that we improve all the oncologic outcomes and symptom scores, and of course from OPRA that we improve the rates of organ preservation. So watch and wait certainly is not without controversy. I'm not going to pretend that people don't have significant problems with the idea that not everybody needs surgery, but this is one controversy that still exists, that those patients who have a local regrowth may have a worse oncologic outcome. And so this is a paper published last year. I've had the PubMed ID for you, for those of you who want to read it. And then we responded to this because there was a lot of controversy that if you have a local regrowth, that there was an association with worse oncologic outcomes and distant metastasis. And essentially what we responded is that seeding distant metastasis is an early event, and that taking out the rectum is unlikely impacts that, and that tumor response is time dependent. So if you remove the tumor in the middle of this response, you essentially don't allow the patient the opportunity to potentially preserve the rectum. And response, as I've shown you, is a strong surrogate of oncologic outcome. And the idea that everybody gets a TME, I think, has certainly passed. And so watch and wait, as I've noted before, is, I think, here to stay. So how can we better improve this response? How could we reduce the local regrowth rate, for example, or better improve survival? So there is some data, and this is some data from my lab, showing that in our model of rectal cancer organoids or patient-derived organoids, that when we test this regimen, doublet chemotherapy versus triplet, we in fact see a response difference, so higher response rates in these patient-derived organoids compared to using a doublet approach. And we know in the metastatic setting, when you use irinotecan, that we see a reduction in tumor size in both the primary and the metastatic lesion, and the patients also feel better. There's evidence across tumor types. This is pancreas, and this is a pooled set of studies in rectal cancer. And you can see, using this triplet approach, that in fact there's a higher overall survival in pancreas and disease-free survival, higher rates of past-CR in rectal cancer, and higher rates of disease-free survival or improved disease-free survival using a triplet versus a doublet approach versus standard therapy. So what about in colon cancer? Well, it's certainly being tested in this Canadian trial. We don't have the data yet, but triplet versus doublet. And then my medical oncology partner here now at MD Anderson, Arvind Dasari, is testing this in patients who are positive for ctDNA, where they're being randomized to either doublet or triplet. And you would anticipate those are higher risk patients being randomized to the triplet arm. And then Aparna Parikh at MGH is also testing this in the context of positive ctDNA in stage 3 colon cancer patients. So I think there's going to be a lot of data in this space coming soon. So we asked the patients when we were designing the Janus trial, which I'll tell you about shortly, whether they would prefer to have more radiation or more chemo. And by a large margin, they said that they would prefer more chemo versus more radiation. This has recently been published, and if you want to read through how we did that and question the patients, this was done with the cooperative group and the help with Deb Schrag, which I think was very instructive for us as we designed the Janus trial. So here's the Janus trial, and I didn't anticipate at this time this year I would be telling you it's finished, but it has finished accrual. And the idea here was that we would compare OPRA, the winner of OPRA, which was the consolidation TNT arm, versus a triplet arm. This extrapolating some from the PERDES 23 data, and we used the same three-tiered response criteria with the hypothesis that those patients with triplet versus doublet would have higher clinical complete response rates and higher and improved disease-free survival. And so I can show you the accrual here, and this is, I think, what happens when you integrate watch and wait into a modern clinical trial. Patients want to participate, which is the bottom line. You can see that we were averaging at the end of the trial about 32 patients a month in the trial. I think it even got up to about 35 by the time we got to July, and people were asking us to keep it open longer. Here's where we started, here's where we ended, and you can see there was some worry that you couldn't do watch and wait across the country. Certainly there's some states there that you see that didn't accrue, but certainly it looks like this can be done across the country. And at the end of the day, we had 783 patients that we'll keep track of, and I anticipate the results will be in about 2.5 years. So a lot of people still think about short course radiotherapy, even given the data from Rapido, and our friends at WashU and the people that were ACS heard Will Chapman talk about it a little bit. But if you look at the data, the outcomes are certainly, the response outcomes are lower using pathologic complete response, for example, as a comparator versus long course, where you see higher rates of of response. And similar to, and then I just, of course, talked about the Oprah data. But if you look at the WashU group, in their experience, they do see rates of clinical complete response that are similar to what we see in Oprah, which I think is very interesting. But of course, when it's an institutional study, there's no comparator for those who went on to surgery, for example. And the idea is here that they might be able to reduce some of the toxicity. They didn't really do a toxicity comparison here. Some people feel like short course is a little bit more toxic and a little bit harder to operate in the pelvis in those patients, but they don't seem to see that. But I think that this group is contributing nicely in this space. Just keep an eye on some of the work that's going to come out of that their group. We tested this during COVID because we did a mandatory short course approach to try to reduce the exposure of patients. So we went back and looked at those patients treated with standard TNT versus short course TNT. And we, in fact, did see a higher rate of local regrowth, which is why we've not used it at MSK as a standard approach. And then, of course, higher rates of organ preservation in those patients treated with a long course TNT approach. So this will be tested in the German trial. I think definitively, where they're essentially doing an arm according to Rapido and an arm according to their data, and also Oprah. This trial, I think, will read out in about a year. So keep your eyes open, not for this ASCO, but I think the following ASCO, because I think this will be very interesting. And you can see from Manos' focus slide here that the recruitment was very similar to what we saw in Janus. When you offer a watch and wait approach in a modern trial, you're going to accrue patients quickly. So in Japan, they're also doing TNT, and this is a big deal because they had never done TNT. Of course, for people who know surgeons from Japan, that they essentially just operated on people that had rectal cancer, and then, of course, they did adopt chemoradiation at some point, but TNT was certainly foreign to them. So this is the first TNT trial that's being done, and I've been really excited to collaborate with them from the beginning. And they're doing essentially Janus, but using short course. So this is doublet versus triplet after short course, using the endpoints of disease-free survival and, of course, organ preservation, and then just seeing if they can do it in Japan. I think this is going to be a very interesting study. So I mentioned early on that maybe patients could potentially avoid radiation. And in my view, the data from Prospect, as you can see here, where patients were selected to undergo chemoradiation based on response versus the standard approach, which was chemoradiation, surgical resection, and adjuvant therapy. In this study of almost 1,200 patients, they saw that using this approach, where you can see my patient here had a nice pathologic complete response. This was published simultaneously in New England Journal of Medicine, and also this is from Dr. Stragg's ASCO presentation, that there's no difference here. The non-inferiority endpoint was met. And in the context of the Prospect trial, I think of this as using selective use of pelvic chemoradiation, especially when you're thinking about young patients, especially tumors that are in the mid rectum that meet these criteria. I think this is a very reasonable approach. But it certainly brings up the idea, well, if you're doing this for locally advanced tumors, why not for early stage tumors? And so, of course, people have been thinking about this for a long time. This is a patient with a very low, looks like a potentially T1, T2 by MRI, endoscopy, but in fact, at resection was a T1 tumor. So she was cured, but could you have done that differently if you, for example, in this tumor gave chemoradiation and it went away? So this is being tested currently across the U.S. by Hagen Kinnecke and his surgical partner, Carl Brown, in the CO28 study. This was initially the NEO study. Now it's the NEO-RT study. The data, the bottom line result here is that they saw about almost 80% organ preservation without the use of chemoradiation. This was their single arm kind of signal finding study. And now they've moved to doing it in a trial that I'll show you in a second. But some of the basic fundamentals here were built by what we learned from the Z6041 trial with T2N0 rectal cancer, where patients were treated with chemoradiation and then local excision, and then TME if they had high-risk features. And what I think you see from this study is that we could achieve easily at least 50% organ preservation using this approach with just chemoradiation alone. And there's a recent study that I'll call your attention to in JAMA Surgery, which there's many studies that I could point to, but I pulled this one just as an example for chemoradiation and local excision, which is essentially equivalent to TME. The endpoint here was local regional recurrence, and you can see there's no difference at all in these curves are completely overlapping when you compare chemoradiation and local excision. And it brings up the idea, do you even need, would you need local excision if they had a complete response? Because the oncologic outcomes look quite good. The neo outcomes related to GREC-R2, CARTS, Z6041. I don't have time to cover GREC-R2 or CARTS, but if you want to read about early stage rectal cancer, those are two foundational trials in this space. But you can see that the neo results are comparable, especially as it relates to local recurrence-free survival to these major trials that have recently been published. So this is the NEO-RT study led by Hagen and Carl. It's randomizing patients to FOLFOX or chemoradiation. And then if they have clinical complete response, they can be observed, or you can do local excision. Near complete responders, similar to Oprah, have time to turn to a complete response. And they brought up this idea that if a discussion is had that you don't need to do local excision unless it's felt that it's necessary by the surgeon. So the eligibility is kind of what you would think of as a classic case for somebody who's eligible for a local excision approach. And the accrual is a little bit slow to begin. So I bring it up because I think this is a very good trial to think about adding if you haven't added it, because I think the fundamental question here is really important to answer. The chemotherapy is standard. The chemoradiation is standard. Nothing fancy in this regard. And then the transanal endoscopy or the local excision approach is up to the surgeon. And certainly you might see some residual disease. So I think it's important to still have that as an option in these patients. The surveillance program is almost identical to what we had in Oprah and Janice, and we collaborated with Hagen to make sure that there was some consistency there. They're also looking at important quality of life indicators. So I'd encourage you to accrue to that study if you haven't. The other trials that have recently read out, but we don't have the final data, is the Star Trek trial that was done in Europe comparing long course versus short course in this space. And the preliminary data at ESTRO showed that long course was superior to short course. I know that they're still working on the final representation of those data, so it'll be interesting to see what they end up showing in Star Trek. So in early stage rectal cancer, certainly with just chemoradiation and local excision, if need be, you can get a very high complete response rate, as I showed you from Z6041. And the idea of an ideal watch and wait candidate here, I think it's very similar to what we see in locally advanced rectal cancer, but this needs to be tested, and it is being tested in the NEO-RT study, which I think is another reason to accrue to it so we can gather more data. And it's a bit provocative to see, could we push organ preservation in this space to more than 70%? And certainly seems that we can. And then the Star Trek trial, as I mentioned, seems that long course is superior to short course in this particular context. So now to the patients who, everybody who comes to clinic wants to be in this space, and this is the mismatch repair deficient group of rectal cancers. And this is seminal paper that we published in New England Journal where we used PD-1 blockade and used the same assessment criteria that we used in OPRA. The idea here was that we had some data to suggest that if there was residual disease, that these DMMR patients would be exquisitely sensitive to chemoradiation. So we thought that would be a good rescue strategy. And to our surprise, we saw that all of the patients in the trial had a clinical complete response, and this was noted by endoscopy, MRI, and also PET scan was used in this study. And you can see the mature data. This was just published earlier this year. This is the presentation by Andrea, but then initially or finally published this year. We see that there's a remaining 100% complete response in the rectal space, about an 80% response in the colon space. And then this is just an accumulation of all of the DMMR tumors across the board at MSK. And I think this is, a continued signal that is very provocative in the rectal cancer space. This is being tested across the world in the AZURE-1 study. And so this will be important as a validation study. It's a similar design and the similar assessments. Everything is going to be evaluated here. And I think this will be an important contribution going forward. This has obviously also been tested in other places. This is the data from a Chinese cohort using their PD-1 inhibitor, and you can see very high PathCR responses. Some of these patients went on to clinical complete response, and I think this is them just testing the signal to see if they could watch patients. We know from our own data, and this is a paper that we published in Nature Medicine 2022, that there is a subset of mismatch repair proficient tumors that have immune hot tumors. So you'd think that maybe there's a group of mismatch repair proficient tumors that could act similar to this 3 to 5% that we could treat with immunotherapy, but we haven't identified this group yet. Some additional interesting data is coming from the TORCH study that was recently presented, not yet published, but you can see that using this approach of short course and then chemo, so chemo immunotherapy, and then the idea of assessing similar to what we did in OPRA might lead to high rates of complete response or clinical complete response. You can see the clinical complete response are a little bit higher than what I just showed you from the updated German study at about 43%, and the complete response rates are in the mid 50s, which I think is very interesting using this approach as we move forward. And then this is the early stage data, and you can see this was also just published last week. Very interestingly, they saw greater than 70% complete response using that approach in early stage tumors. This is work from one of our prior fellows who's now in Scotland, Campbell Roxburgh, who hypothesized that using short course versus long course and then PD-1 plus FOLFOX, so again, this idea of chemoimmunotherapy might lead to higher rates of organ preservation. This was also presented at ESTRO, and what is interesting is, and similar to what I just showed you, is that short course seems to be associated with higher rates of response in this context versus long course. And I think the idea here is that you spare the nodes in the pelvis, allow the immunotherapy to work, and then see what kind of response you're going to get. So we've certainly seen a big response in our mismatch repair deficient rectal cancer patients using PD-1 blockade alone, which I think is very interesting, and we need to continue to follow those patients and see how that plays out. There's other trials that have used combination like CTLA-4, LAG-3, and this is ongoing in both the colon cancer space and in rectal cancer. And we know that in the colon cancer space, that the use of these immunotherapy agents is associated with excellent survival and very, very good major pathologic response. And the trials that I told you about, TORCH-E, which is for the early stage, and then PRIME-RT are showing rates of response in the 30 to 70% range. And this, provocatively brings up the idea in early stage resectable colon, and you use PD-1 blockade in the DMMR space, do all these patients need surgery? So durability of response is still something that we need to learn, and the biology of response, I think we don't understand. So I'll just put it in a picture here about how we think these tumors respond. This is a mismatch repair proficient tumor treated with chemoradiation and chemo. You can see a nice clinical complete response. radiation and chemo. And really, this means that biology, I think, is still king. And then here you have a very selected approach with mismatch repair deficient tumors that are getting PD-1 blockade. And here you can see a very nice clinical complete response with PD-1, 6 cycles of PD-1 blockade. So response really still remains the best indicator of biology at present until we learn more about how to use both chemo and immunotherapy in the mismatch repair proficient space. So people always ask, well, how are the NCCN guidelines changing and what's new? Interestingly, this is as of August 2025. This has not changed much at all using a TNT approach for mismatch repair proficient rectal cancers. And this is the prospect approach that I mentioned to you earlier. That's certainly viable. And I think of that as a way to approach patients who want to avoid radiation, especially tumors in the mid to upper rectum. And of course, it's mentioned here that you could do surveillance or watch and wait. That's what these items in the guidelines suggest. And clearly, there's now a move that you have to know what the molecular profile of the tumor is before you start neoadjuvant treatment. And then this is just the guidelines for mismatch repair deficient tumors using PD-1 blockade, as I just noted. It's still thought that patients could be treated with a TNT approach, but I think given the data that we have, that not starting with the immunotherapy approach would be quite difficult in the current era. And then obviously observation for those patients who have a clinical complete response can be offered. In terms of trials that are ongoing, using this chemo immunotherapy approach across the world, there's 5 phase 3 trials ongoing. There's 10 phase 2 trials. So this is certainly a hot topic and one that I think we will learn a lot about in the coming 2 to 3 years and determine what's potentially the best approach. So what about ctDNA and then the post-OPRA impact? And I mentioned the NEO study. These are data from the NEO study. This is using a tumor agnostic ctDNA assay. And you can see that in those patients who had residual tumor, even though the detection rates were relatively low across the board post chemotherapy, in those patients, you could see that the molecular test proved helpful in those patients, and that even though the chemotherapy or the circulating tumor DNA rates of detection were quite low, that it seems to be an association with those who had residual disease, which I think is an interesting signal and is being tested in Hagen's current trial. We know from the work here, this is work from MD Anderson, in the patients that were treated. These were DMMR GI solid tumors treated with PD-1 blockade. You can see that it's positive ctDNA is certainly prognostic. And interestingly, in those patients managed non-operatively, if you had negative ctDNA versus positive ctDNA, the 2-year EFS was 100% versus 33%. So I think there's certainly a signal there and certainly something worth testing prospectively. There's a recent study from Japan. This is just published a couple of months ago in Clinical Cancer Research, where they used a similar consolidative TNT approach and also a sandwich approach. You can see all the blood draws, up to 5 blood draws throughout this study. That's called the Nominate study. Not surprisingly, positive ctDNA is prognostic, but the question really is it predictive? And by that, I mean, is it predictive of sustained response? Is it predictive of clinical complete response and organ preservation? There's maybe a signal here, and this is a tumor-informed assay. You can see in those patients who had a complete response, the drop in ctDNA or the ctDNA clearance on the left versus those who had an incomplete response on the right. And we see something similar in the DMMR space. This is from the New England Journal paper using also a whole exome approach, where the patients also have a complete response, have a significant and seems to be a sustained drop in their sustained clearance, which is, I think, an interesting signal, but this needs to be tested prospectively. So the post-OPRA effect, as you look across the world, you see multiple phase 3 trials ongoing. Essentially, all of the trials have a watch and wait approach. There's one exception to that. You can see those trials that are testing doublet versus triplet, and a number of trials testing this chemoimmunotherapy approach. This doublet versus triplet question, I think, is going to be well answered by these studies with thousands of patients, which will help us answer this question, I think, even more definitively than what Pradesh told us. ongoing trials that are using CCR as an endpoint. I've used the Janus trial, the Chow trial that's being led by Rodrigo Perez in Brazil, the Ensemble trial that I talked to you about, and the German trial. All of these trials are using clinical complete response, and we plan to pool these data together to help us identify sustained responders. This is a working group of the German group, Japanese, the Brazilians, us, and now, of course, we've added MD Anderson to this group, where we're trying to figure out how to best identify these sustained responders going forward. So I'll end with just a couple of thoughts on some gaps that we need to fill. I think I mentioned early on that we need to improve survival. The idea of modernizing radiotherapy was certainly something fundamental in the Janus trial, and I think we'll learn about that as we expanded modern radiation delivery techniques across the U.S. We want to improve quality of life, and if we preserve the organ, we hypothesize that that would be better. I mentioned multiple times that we want to identify these sustained responders. I alluded to how ctDNA could be potentially used, but I think best tested in a prospective fashion, and we're working on building those data in all the ongoing trials. So hopefully that will be instructive for us. Identifying the optimal patient for TNT, I think, is also an important question so that we can reduce toxicity in those patients that don't necessarily need all of the treatment modalities, including radiation, like I talked about in Prospect. So in summary, I've covered, I think, the data, at least from my perspective, which could be a little bit biased as it relates to the watch and wait approach. I'll certainly admit that, but I hope I covered some of the fundamental studies as it relates to that, what makes up an ideal watch and wait candidate, and then how to best gauge response and how that is associated with survival. So the data there that I showed you were OPRA, which is the first randomized trial integrating selective use of watch and wait, and that showed it was safe with an excellent response rate. And I certainly say this is best to be done on protocol if possible, given resources, surveillance. The trials that are ongoing using watch and wait are the NEO-RT, the Ensemble, and the Chow trial. There are some other smaller studies that you can contribute to, I think, locally, that would be very interesting, and we learned from all those trials. But I think the key point is to have watch and wait integrated because patients are interested when they can save their rectum. In terms of sustained responders and those criteria, that's being validated. I think that's very important to continue to validate that three-tiered response criteria as we move forward. And the role of ctDNA in this space as it relates to the prediction of who's going to have a sustained response, I think is still, we have much to learn and to be determined. The highest rates of organ preservation are those who have a consolidative approach, that's chemo after long course chemoradiation. Of course, I showed you the data of improved overall disease-free and all essentially oncologic outcomes using triplet chemotherapy versus a standard approach in the PREDIGE 23 data. And then I covered the Janus trial, the new German trial, and then mentioned the Brazilian trial that's ongoing, and then the important trials that I think you should know about, including the Ensemble study and the NEO-RT study. This chemoimmunotherapy approach, I think, is very interesting and still allowing patients an opportunity for organ preservation. So much more to come in that space. In terms of a simple cartoon of what I think people need to know, especially in the current day and age, this is something that I made with one of my recent fellows who's now at Mount Sinai, Aaron. But I think the bottom line when we name, stage, and treat these patients is in the current era that if you don't know the MMR status before starting neoadjuvant therapy, you need to pause because there's certainly a big difference in the response and how these patients are going to do. And then also using a very selective approach as you think about which TNT approach to use to either achieve a clinical complete response. And of course, I also like this because it still suggests there's a role for a surgeon in the modern era because we know that not all the patients are going to respond with a clinical complete response. So I'll end there. Thank you for the opportunity and happy to take questions.
Thank you very much, Dr. Smith. This was an amazing talk. There are no questions in the Q&A, so I'm going to start with a practical question. We have a few practicing physicians in the audience, so something very practical. Patient comes to you with a low rectal cancer, young individual, MMR proficient. Let's say a woman wants to start a family, T3 and 1 with clear circumferential resection margin. How do you
Hmm.
approach it, and how do you discuss the options with
Yeah,
such a
I think
patient?
it's a great question. And in the context of what they want in terms of survival, I think is important, and also in terms of sexual urinary um, function, also bowel function long term for a very low tumor like this, and a woman who hasn't started her family. And I mentioned my patient early on; she hadn't started her family. Unfortunately, she'd already gotten chemoradiation, so it was a little bit difficult for her. But in this case, when you have somebody um, who hasn't received treatment, there's many different options now where you can bring the ovaries out of the pelvis. If it's really important to the patient to preserve the rectum, there's, as you know, Dr. Fakera, there's many patients who say, you know, I ain't having just I'm not gonna have a stoma, no matter what. And so if that's really important to her, then I think what you suggest is the best available data is chemoradiation and chemotherapy. But let's think carefully about how we're going to preserve your fertility, which means you expand your team from just medical oncology, radiation oncology. The GYN team, for example, at MSK has done multiple, and I've done one recently just before I came with them with a woman who wanted to preserve her fertility, and that worked out well. Of course, it makes things a bit more complicated, but that's fine. I think that's very individualized care. Um, you know, could you also achieve? I think you bring up a interesting point. Could you also achieve a clinical complete response with chemotherapy only and avoid radiation in some of these scenarios? I think you very likely could. In Prospect, and I didn't dig into the data for the sake of time, but in each arm, the pathologic complete response rates were in the mid 20s. So if you had waited a little bit longer, um, can we get complete response rates with just using chemo alone? So I would have a very uh, careful conversation with that patient about what she wanted. And many times it's survival. Sometimes they don't care about organ preservation, especially young patients. They prefer a survival advantage. They want to be here longer, and some patients prefer surgery, to be frank. And at the end of the day, a high quality TME is really important, and the ability to reach a surgeon who can do that effectively is also key.
Great. And if any of the other panelists have questions, just please raise your hand and then ask. So while we wait for more questions, you brought up Prospect, and I want to hear your opinion. How do you position Prospect? Right? We know that consolidation chemotherapy is the way to go. Prospect does the opposite. We are now looking at triplets, and Prospect doesn't do that. So how do you, in your practice, position Prospect?
Yeah, I think I alluded to it a little bit in the talk, but I think for those patients who want to avoid radiation and they're good candidates for a low anterior resection um, in the mid to upper rectum, I think that Prospect is a good option for those patients. From if somebody has a very low rectal cancer, or it's in a mid to low rectal cancer, I think they're interested in organ preservation. I think the data is very strong in that regard, and that's another reason that I brought up the German trial, or the study that was kind of their preamble to what I think they're going to potentially show in their randomized study, that there's certainly a fairly high rate of organ preservation using that approach. It's still provocative. I think you bring up a point of, could you observe some patients that have mid to upper rectal tumors that have a complete response after chemo? But it hasn't been tested yet. It's certainly, for anybody in the audience that wants to do a study like that, I think it's certainly possible. And there's a lot of patients who would like to avoid radiation if possible.
Yeah, Dr. Shah, you want to ask a question?
Josh, that was a great talk, and thanks for that overview. I wanted to ask you about the ctDNA data. So, we um, did a trial with immunotherapy in colon cancer, and it turns out that most of the patients that where we got the ctDNA before starting treatment had a positive level, which I was surprised by for localized disease to have a positive ctDNA for apparently non-metastatic disease. So one is that something that you guys have seen as well? And then the other thing that we noticed is that it cleared almost in everybody, at least on that trial, whether pathologically you had a major response or not. So then it makes me think that maybe ctDNA is not a great marker for path response. And so I wanted, you have data on that too.
I think that's a great point. The data I showed was in the tumor agnostic setting in the early stage. You saw that the rates still at the beginning in the early stage were relatively low, about 40% detection using that assay. And the data in the mismatch, in the locally advanced was a tumor-informed assay, but it was whole exome. And the reason I bring that up as a detail is because I don't know, Dr. Shaw, if whole exome is sensitive enough in this space to, for example, tell me the difference between somebody who has a sustained response versus somebody who's going to develop a local regrowth, because you might hypothesize that somebody who's going to develop a local regrowth never truly clears, right? Because yes, we think that the detection rate at the beginning is quite high, but I think what's interesting from that study I showed you is that in the complete responders, they seem to continue to have low rates of positive ctDNA detection versus the incomplete responders. The question really becomes, in that group that are complete responders, is it predictive of that sustained response? And these using a single observational study is not going to help us answer that question. We need to test it in a randomized setting. And my thinking at this point with whole exome is that that's probably not enough. I think we need the better technologies that are available now, like whole genome, to help us with that. There will be some data coming from a small subset of patients in OPRA that could be instructive there. It's not published yet. And there's other data building. For example, the Japanese, I think, are presenting data soon in the space. So I think we'll get a signal, especially as it relates to whole exome, whole genome, and be able to better identify those patients who have a sustained response. And that should correspond to your question to pathologic complete response. Because we know, and I think another reason I brought up the German trial or the German study that's just finished, their pass CR rates were quite high. It'll be interesting to see what their circulating tumor DNA, did those patients clear? Because clearly from a clinical standpoint, we're still not great at picking out those patients where we think, oh, that's residual tumor. And in fact, on pathologic analysis, there's no tumor there.
Great. If there are no other questions, I will let Dr. Smith go back to your daily activity. I know I can speak on behalf of everybody here at Cornell. Are missed, sorely missed from across the street. And you delivered another great talk. I was at ACS, and you gave a great talk there. So again, you'll be missed. And thank you for taking the time to talk to us.
Thank you so much. Have a great day. Thanks.
Thank you.
Bye, Josh.
Bye. Take care. Good to see you.
All right. Now we're going to leave a little time between.